that brings me to two questions I want to ask about these drugs. One is, we have midostaurin, I'll throw in their sorafenib, very non-selective FLT3 inhibitors, and now you have the more selective ones. Do we know at this point what's the optimal approach to these patients?
I don't think we know. I think I have reason to think that it makes sense logically that we should use a highly selective, highly potent FLT3 inhibitor. But look at midostaurin, which all the data would suggest is pretty broad in its activity, and yet it's been active. We don't really know. And I think the design of comparing a selective potent inhibitor to a less selective inhibitor added to the same backbone of therapy is really what we need to do, just a study like that.
Right, because exactly, there was data in FLT3 negative wild type patients that there was activity. So maybe we need a broader kinase inhibitor. I mean, there's been speculation, up front where there's many, many clones, high bulk disease, a lot of different subclones in there. Maybe a broader would be better. Waiting until relapse, a highly potent, dominant FLT3 driven clone might be better, but I don't think we know. I think
that's going to be a very important question for us to figure out.
What do you think, Jorge?
Oh, I confess my total ignorance. I don't know what is best. And I think that there's elements that are good for both approaches that you both have mentioned. So I think that we, at some point, we're going to just have to do the comparisons. And it may be that it's for subsets that one is better than the other.
So well, like CML maybe, like they have different tyrosine kinases for different situations,
Sure. So let me ask the expert here. I'm just an investigator on these studies, but I have noticed one thing with the single agent FLT3 inhibitors I'd like you to explain to me. They have been very effective at clearing peripheral blood blasts and even clearing the marrow. But many of my patients don't recover counts.
Yeah.
Why?
Yeah. This is a complicated answer, and I know we're limited on time.
No, in 15 seconds.
In 15 seconds. These are complex diseases with multiple mutations where you're using one drug to target one mutation. You can't get rid of everything else with that one drug. Now, one thing we've noticed is there is differentiation to FLT3 inhibitors, and that pushes towards a myeloid bias. That doesn't generate a lot of platelets or red cells potentially. We also do see patients that clear the FLT3 mutated clone, but it may leave behind clonal hematopoiesis with other mutations that aren't targeted by the drug. So I think what you really need to do is combination. Asking one drug to do it all is really hard.
Right. And FLT3 inhibitors, FLT3 mutations are late events in leukemogenesis. So just as you said, you have this soil then that is still, not the soil, but the seeds, those cells that still can mutate and still have an underlying hematopoietic stem cell defect.
Right.
Right, and really canolinib in the studies that were done with 7 and 3, actually the count recovery was not affected. And I think c-KIT is a particular kinase that has been associated maybe with hematopoiesis and count recovery, and canolinib, at least theoretically, doesn't hit c-KIT.
So I'm going to throw a hypothesis about this, and I think that one thing that we probably have forgotten is, we think about the inhibition of c-KIT, for example, by some of these, but FLT3 has a normal function in hematopoiesis.
Right, absolutely.
Yes.
We're talking about the mutated one who is constitutively activated, but FLT3 with its ligand then has a normal function. If we're inhibiting it, even when the ligand is functioning in the normal hematopoietic cells, we probably are not letting those cells proliferate. And there is this concept that when you give chemotherapy, there is an overexpression of the ligand that there's been assumption of how best to sequence, but maybe they recover well after chemo plus the inhibitor.
Because they need the ligand.
Because they have this overexpression of the ligand. It's a hypothesis, I have no proof, but could it be that be the reason why they don't recover with single agent?